sharing one of my screen. This is so today we will do the your genitourinary tract. Before just starting, I just wanted to share you one thing from yesterday's about your Crohn's disease and ulcerative colitis. So Preeti Singh, I just checked it, and you are right that ulcerative colitis, it has pre-malignant condition which is more common, and Crohn's disease also has that pre-malignant, but it is less common. Okay, so that's it. So now start with the second of genitourinary tract about urinary renal calculi. Okay, so so first they will ask you about the type of the stones. Okay, so they are basically how many type of the stones? The fourth type, one is cystine, calcium, uric acid, or the Struvine stone. Okay, so sometimes the Struvine stone is also known as a triple phosphate stone. Okay, this Struvine stone, it is also known as a triple phosphate stone. Okay, so let me write it here. Triple phosphate. So peak incidence of the kidney stone is usually in the young age, in the adult, that is in between the 2 to 40 years. Okay, so during this year, the peak incidence of the peak age will be 20 to 40 years. Okay, there are some pointers. For example, in the female, infectious stones are more common, means they have recurrent uterine infections, and infectious stones are the more common, which is the struvite stone. So in female, infectious stones are more common. Okay, infectious stones are more common. If they ask you what is the most common symptoms of the kidney stone, if they ask you what is the most common symptom of the kidney stone, okay, so another MCQ, the answer is the pain. Okay, the pain is the most common symptoms of the kidney stone. Remember, the severity of the stone does not depend upon the size of the stone. It depends upon the type of the stone. Okay, so pain does not depend upon the size of the stone. So even if the size is 1 millimeter, if it may cause pain. Okay, or even if the size is 7 millimeter, it does not cause pain. Because that means the pain of the kidney stone does not depend upon the size of the stone. It depends upon the type of the stone. And most common, the painful stone is the uric acid stone. Okay, so uric acid stone, among all the stone, the most painful stone is uric acid stone. Okay, so this is the most painful stone is the uric acid stone. Okay, okay, now let me write it here. Now, for example, if they ask you what is the what are the type of the stones, okay, now what is the most common type of the stone? Okay, the most common type of the stone is calcium oxalate. Okay, the most common type of the stone is calcium oxalate. So the calcium stones or the calcium oxalate stones are the most common. Okay, so most common stone among the four is calcium oxalate stone. Okay, so usually seen in those patients who are suffering from increased level of calcium in the body. Okay, I think I have not given this. I have not. So the most is if there is an increase of calcium ion in the body. So the might be suffer from the hypercalcemia, hypercalcaria, or the hyperoxaluria. Okay. the stone will be small, hard, and the jagged stone. Okay. So the calcium stone, if you see that there is a numerous stone, multiple stone, they are the small stone and very hard stone. Okay. Small, hard, and the jagged stone. And this type of the calcium stones are mostly your radio opaque. Okay. That means you can easily, they are visible in the X-ray. Okay. So calcium stones, they are the radio opaque stone, small, hard, jagged stones, and they are the most common type of the stone, usually seen in where there is an increase of the calcium ion in the body. The second is your uric acid stone. These are the radiolucent stone. Okay, so these are the radiolucent. Okay. 1 minute. So these are the radiolucent stone. Okay, and uric acid stone, they found in the mostly in the acidic urine. Okay, usually the person who suffer from increase in the uric acid, or they are having some what to say, some diseases, they're suffering from the gout, they're increase in the uric acid in the blood, they mostly suffer from this uric acid stone, and uric acid stones are the most painful one. Okay, now come to the struvite stone. Okay, with the other name of the struvite stone is a triple phosphate stone. Other name is a triple phosphate stone. So triple phosphate, that means it contains calcium. What are the thing that is a calcium phosphate, magnesium phosphate, and the ammonium phosphate. So what are this? Calcium phosphate. So I'm just writing it here. That is calcium, magnesium, and the ammonium. The stone is made up of calcium, magnesium, or the ammonium. Calcium phosphate, magnesium phosphate are the ammonium phosphate. Most commonly seen in infectious diseases. Okay, the person who is suffering from the recurrent UTI infection, okay, especially in the female who are suffering from the UTI infection, their urine become alkaline, and they have more chances to develop this struvite stones. Okay, struvite stone. Usually, there are the two bacteria which are responsible. One is your E. coli, okay, and the other is your 1 minute. One is your, yeah, it's mostly in the proteus infections. Yes. So one is E. coli and other is your proteus bacteria. Okay. So mostly common seen in the, but most commonly in the proteus and then to the E. coli. So they are most commonly seen in the female. The urine will be your alkaline urine. Triple phosphate stone, ye yaad rakhna. What are the calcium, magnesium, and the ammonium phosphate? Usually seen in the those who are suffer from the recurrent UTI infections. Okay, and this type of the stone is look like a staghorn calculi. Okay, so they can they are not easily breakable. Okay, and they look like a staghorn. Okay, they look like a staghorn, and they resulting into the progressing destruction of the renal parenchyma. So they causes is, in the later stage, they causes destruction of the kidney parenchyma. Okay, so there is a progressive destruction of the kidney parenchyma. Okay.
Ma'am, most common in female.
Sorry.
Most common in female.
Most commonly in the female. Most common in the women who are suffering from the recurrent UTI infections. Okay, those who are suffering from the recurrent UTI infection. Okay, Okay, so ये हो गया, and these are also called as your staghorn calculi. Okay, now come to the another one, which is about your cystine stone. Okay, so this is about your cystine stone. So cystine stone is another type of the stone, which is a rare one, and they are found in the acidic urine. Where they are found? They are found in the acidic urine. Okay, so write it here. Found in the acidic urine. Okay. And other are the xanthine stone. Okay, so wherever there is a defect in the p urine metabolism due to some genetic deficiency. Okay, they are also very rare. They are due to the defect in some p urine metabolism. So 1 minute, huh? Defect in the urine metabolism. Okay, so maybe there are some genetic deficiency of some enzymes such as your xanthine oxidase. There is a metabolism defect which resulting in this xanthine stones. Okay, most commonly अगर क्वेश्चन पूछा जाता है mostly from the calcium oxalate, mostly from your uric acid and the stovite stone. These three stones are most important for your AIPGT. Okay, okay, okay. Now, where the stone is situated. Now, suppose the patient has come to you with pain in the kidney region, pain in the bladder, or pain in the ureter. Okay, so from the depend upon the clinical feature, you can or depend upon the pain where the from the clinical feature you can understand, you can make out where the stone can be stuck. Okay, so I'm just removing this. Now, if the stone is in the upper ureter, okay. So now if the stone is in the upper ureter, okay. Now if the stone is in the अगर यहाँ पर stone stuck हो जाता है, ठीक है, in the upper ureter. Okay, so this is a stone. I'm just okay. If the stone is in the upper ureter, then the pain is referred to that. In case of male, the pain going towards the or referred to the testes in male, and in case of the female, it is in the labia majora. So it is in case of male, and in case of female, the pain is referred to the labia majora. Labia majora. Okay. So when the stone is in the upper ureter, okay. When the stone is in the mid ureter, okay. When the stone is in the mid ureter, okay. Then if it is in the right side, it will sometimes mimic appendicitis. So, okay. The pain is in the right iliac fossa if it is in the right iliac, and if in the left ureter, the pain is going towards the left iliac fossa to the iliohypogastric nerve. Okay, so if there is a pain in the right iliac fossa, you will think that it can be due to the appendicitis. Okay, there might be due to the kidney stone also. Okay, if the stone is stuck into the mid ureter. Okay, now if the stone is stuck into the lower part of the ureter, okay, suppose especially into the lower part of the ureter, यहाँ पर बनाते हैं, especially in the lower part of the ureter. Okay, if the stone is stuck here, okay, then the pain is referred to the thigh, scrotum in case of male, and the perineum. Okay, so pain is referred to that of the pain is going towards the thigh, scrotum in case of a male. Okay, on a case of female, it's going towards the thigh, and there is some pain towards the perineum. Okay, in the perineum. Okay. So now suppose a patient is only complain of the back pain. Only complain.
मैम रिपीट
Sorry.
मैम फिर से एक बार रिपीट कीजिए लोअर पार्ट ऑफ यूरेटर और
Okay, so if the stone is stuck in the lower part of the ureter, then the pain is referred to the thigh, scrotum in case of male, and the perineum. Okay, so thigh, scrotum, and the perineum. Okay, हो गया? So this is upper, middle, and the lower. So from the clinical feature also you can distinguish, or you can make out. Sorry, you can make out where the stone is stuck. From the when the patient they are saying कि हाँ इधर से मेरा दर्द यहाँ तक जाता है. Okay, where the pain is referring, where the pain is going. Now if the now suppose now the stone is in the bladder, or it's approaching towards the bladder. Okay, it is towards the bladder. Okay, or it is in the bladder. So what are the most common symptoms? That is your bladder frequency. So frequency of the urination increases. Okay, बार बार यूरिन जाना पड़ रहा है. And then also there is an urgency. एक बार अगर मुझे यूरिन लगता है तो मैं रोक नहीं सकता. That is your urgency. And the third one is your painful urination. Remember, if the stone is in the bladder, most common symptoms the patient will tell you that is the pain at the end of the urination, at the conclusion of the urination. जब यूरिन जब शुरू करता हूँ तब उतना पेन नहीं होता. जब मैं खत्म होने को आता है, that there I am suffering from severe pain. Okay, especially when the stone is in the bladder. So frequency of the urination increases, urgency increases, and dysuria also. So pain while urination, and especially pain at the conclusion of the urination. And this is a very common symptom. If you read Allen's keynote, it is a very common symptom of the Sarsaparilla. So Sarsaparilla is most commonly used in the bladder stone. Okay, so this is all about your and depending upon where the stone is situated, you can from the type of the, not from the type of the stone, from the character of the pain, you can distinguish what type of medicines you can give. Right kidney में अलग है, left kidney में अलग है. That is during the therapeutic. Okay, now let's move to the, this is all about your kidney stone. Okay. Okay, one thing that is, most of the renal calculi stones, they are the radio-opaque. Okay, 90% stones are the radio-opaque. Only your uric acid stones which are radiolucent. Okay, so 90% stone of kidney stones, they are radio-opaque. Only 10% you can see in the and others are the radiolucent. The most commonly the uric acid stone is your radiolucent stone. अगर पूछ सकता है कि what are the radio-opaque stones and the radiolucent stone, the uric acid is your radiolucent, and the xanthine stone is also radiolucent. Okay, and the xanthine stones, they are also the radiolucent. Most common investigation, X-ray, KUB, okay, kidney urinary bladder tract, or the ultrasonography, the USG of the abdomen. Okay, rather afterwards we can do the CT scan or retrograde pyelogram, all those things. Okay, but for the urine, we have to, the routine examination of the urine also we can do. Routine urine to know if there is a sediment is present or not. If there is an RBC is present, that means there is some amount of blood is there. Okay, pus, what type of the sediment and the deposit. Okay, and in the routine examination of the urine, we can see all these things. Okay, so now come to the, what do you mean by the ESWL? That is your extracorporeal shock wave lithotropsy. Okay, so इसमें सिर्फ इतना ही याद रखो. So basically बाहर से they will give you some sound. Okay, and that will help you to break out the stones. Only those stones which are not that much hard, they can easily be broken down by the ESWL. Its full form is your that is extra corporeal shock wave lithotripsy. Shock wave lithotripsy. Shock wave lithotripsy. Extracorporeal shock wave lithotripsy. Okay, so high energy shock wave are given, okay, from the posterior part of the body, so, especially in those in which type of the stone ESW are used. Difficulty, that is for the कुछ stones के नाम लिख लो, that was written in this, that is bruchite stone, okay, calcium oxalate stone, cystine stone. Okay, so from this type of the stone we can go to the extracorporeal shock wave lithotripsy. Okay. So what are the complications of the ESWL? The complications, sometimes it can result in acute injury of the renal parenchyma. So what are the complications? Obviously, if there is a sudden sound or there is a shock, sudden shock, it can resulting in the acute injury of the renal parenchyma cell. Okay. Sometimes what happened, there is an infection due to the release of the some fragment. Okay, infection in other part of the body or in the ureter due to the release of bacteria in the fragment. Okay, due to release of a bacteria in fragment. Okay, sometimes there is a lung parenchymal injury if it is exposed to the lungs. Okay, lung injury is also there. So most common is your acute injury of the renal parenchyma, which resulting into the hematuria or your edema. Okay. So usually on those stones which are used, especially so in which stones ESWL we cannot do? Number one, in the struvite stone. Okay. So for the struvite stone, sorry, और your triple phosphate लिखते हैं. Okay, triple phosphate में we cannot do the ES if the stone is multiple. अगर multiple stone हुआ, okay, if the stone is multiple, so in multiple stone, and if the stone is your triple phosphate, and if the stone is more than 2 centimeter, okay, more than 2 centimeter, we should not do this extracorporeal shockwave lithotripsy. It should be less than 2 centimeter, should be a single stone. Okay, and this type of the stones we can go with the extracorporeal shockwave lithotripsy. There is another one which is known as your PSNL, that is your percutaneous nephrolithotomy. Okay. That is percutaneous nephrolithotomy. Nephrolithotomy. Okay. So what is happening there? An incision is given. Okay, and a tube was an incision was given, a tract, and then a posterior across something, a tube was enters into this part, and the stones were removed from that site. Okay, so usually seen in those cases where there is an if the stone size is more than 2 centimeter, okay, and also in case of staghorn calculi. Okay, so indications for this: if the stone is more than 2 centimeter, if the stone is more than 2 centimeter, if the stone is in the lower pole of the ureter, we can go with the percutaneous nephrolithotomy. Okay, so this is
मैम पिछले वाले में लंग इंजरी का क्या बता रहे थे, थोड़ा एक बार फिर से
तो
बताइए।
बेसिकली इफ इट इज एक्सपोज्ड है, ठीक है, क्योंकि क्रश करके अगर कुछ फ्रेगमेंट्स के लिए अगर लंग इंजोर हो जाता है, that is only. So lung injury is only lung parenchymal injury if it is exposed. Exposed में मतलब अगर कुछ फ्रेगनेंस वगैरह इंजोर्ड लंग्स के parenchyma में अगर लग जाए तो, okay, because they are giving this like pressure में लोग stroke देते हैं, and because of that the stones comes out from the ureter. Okay, they break in small pieces and comes out from the ureter, and while giving that shock, that shock, sometimes it can resulting into the injury of the like renal parenchyma, and from that injured part maybe some of the fragments, stone fragment can resulting into the other part of the organs. इसलिए तो मोस्ट कॉमनली देखा गया है कि लंग इंजुरी होता है, दैट्स इट। ठीक है, ये आज तक आया नहीं है। ठीक है, सिर्फ इतना याद रख लो कि एक्स्ट्रा कॉर्पुलर शॉकवेव लिथोट्रिप्सी में किस टाइप के स्टोन्स को हम लोग ट्रीट कर सकते हैं और किसको नहीं कर सकते हैं, दैट इज ओनली इम्पोर्टेंट, एंड विच टाइप ऑफ द स्टोन कैन डू विद द ESWL. And for the percutaneous, which type of the stone, that is staghorn calculi, stone which is more than 2 centimeter in diameter. Okay, आज तक नहीं आया है, but even then, okay, this is type of the stone is important. Where the stone is situated depend upon कहाँ से pain refer होता है, that is important. Okay, now can you just tell me some of the questions? What is the most common type of the kidney stone?
कैल्शियम ऑक्सलेट।
Calcium oxalate. Okay, very good. Okay, yes. Which modality is the most sensitive for detecting the renal stone? Most sensitive बोला है, most common we know. ठीक है, now you have to tell me the most sensitive is this one. Which one? Ultrasonography and USG, they are commonly used. They should not be. Yes, the answer is C. Okay. ESWL work on which principle? Heat coagulation, electrostatic disintegration, focus shock wave causing stone fragmentation, laser wave vaporization. Yes, the answer is focus shock wave causing stone fragmentation. Best stone for ESWL. Best stone for the ESWL. थोड़ा देखो, ये मिलीमीटर में है। सॉरी, जस्ट गिव मी फ्यू मिनट, तब तक आप इसका okay, just want to, so here the answer will be more if it is less than 25 mm. वो मैंने पिछले में क्या बताया था, if the stone is less than 2 centimeter, okay, but this is in the millimeter. ठीक है, so the answer will be if it is less than 25 mm. okay. तो 1 centimeter is equal to 10 millimeter, तो 2 centimeter is equal to 20 millimeter. ठीक है, so less is your 25 mm. Okay, so let's, which of the
मैम वो
following,
25 मोर देन 25 mm को मार्क किया हुआ था ना, मोर देन 25 mm।
it is less than ना, यहाँ है ना, it is less than 5 ml, it is more than 25 mm. Sorry sorry. Okay, so this will be your 5 to, तब 5 to 15 mm में डालोगे तब, ठीक है, 5 to 15 mm. Okay, now come to the, which of the following is contraindication for ESWL? क्या हो सकता है? Single kidney, hypertension, stone should be more than 10 mm, और pregnancy. Contraindication, shock wave यूज किया जा रहा है, बहुत इजी है, आई थिंक यू कैन okay, the answer is pregnancy. Yeah, everybody is right. चलो, most common complication for the ESWL, ये मैंने करवाया नहीं है, but yes, what is the most common complication for the ESWL? You can search also from your book and then you can write it here also. क्या है आंसर? ओके, इट इज बेसिकली द मोस्ट कॉमन कॉम्प्लिकेशन जो है, दैट इज स्टिनस्टीरेस फॉर्मेशन. स्टिनस्टीरेस फॉर्मेशन, जब किडनी में, एक मिनट, सपोज दिस इज योर किडनी, दिस इज योर यूरेटर, व्हेन वी स्टार्टेड, व्हेन वी आर गिविंग द ESWL, some part of the fragment of the stone, they get stuck it here. Okay, so this is called your Steinstrates formation. The kidney stones break into multiple fragments. Now these fragments move down into the ureter and they line up one behind the one another. Okay, so suppose it's very difficult for me to write it here. So इस तरह से लाइन 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 करके दे स्टक हो जाते हैं. So इसको बोलते हैं street of stones. So basically it is one of the German word that means street of stones. Okay, so they line up one up behind the others. If it is, say, sometimes they causes an obstructions of the ureter. So this is the most common complication. These are also the complications. Okay, but the most common complication is your Steinstrates formation. Okay, मैंने तभी बताया नहीं था. It's only because of this reason. Because there is a formation when the ESW was given, the stone started to fragment here in the ureter. Okay, and they look like a line. Okay, they look like a line up one behind the other, which is known as like a street of stones in English. It's German language is your Steinstrates formation. Okay, so this is the most common complication. Okay, now come to the pyelonephritis or your pyonephrosis. Nephritis, your inflammation of the kidney. Nephrosis is means when there is an pus filled in the kidney. So first there is an inflammation, first there is in some infections, okay, which resulting in inflammation, and after that there is an abscess or a lot of the pus formation in the kidney. Okay, so this is known as a pyonephrosis. Whenever there is a pus, always look at this. There is a feature of fever. Whenever there is an abscess in the kidney, the patient, there is a swelling in the loin. Okay, swelling in the loin, and also there is an anemia. Okay, because of decrease of the erythropoietin secretion. So how will you diagnose the case? By the ultrasonography. Okay. So what do you mean by the pyonephrosis? Means pus filled kidney, a bag of pus. So kidney become a bag of pus, and the most common cause is renal stone. Bas itna hi rakho, the most common stone is renal stone. Okay. Now come to the next part of genitourinary tuberculosis. Okay. So I will write it here only. Okay, what do you mean by this? Genitourinary tuberculosis. So there are basically two types. one is your primary one and another is your secondary one. Okay. So abhi that the first primary that is in the lungs, and when this goes into the other part of the body, it has become a secondary tuberculosis. To remember the genitourinary tuberculosis, they're mostly the secondary one, and the most commonest organism is your Mycobacterium tuberculosis. The most common organism is your Mycobacterium tuberculosis. Okay.
मैं फर्स्ट
And
वाला एक बार फिर रिपीट कीजिएगा ना,
okay.
प्राइमरी
Now
सेकेंडरी क्या
suppose
बोल
this is lung. Okay, kidney. Suppose this is lung. Okay. So यहाँ पर primary focus होता है. ठीक है. The lung, basically TB is always in the primary focus is always in the lungs. So from the hematogenous spread or from the blood, it goes in another part of the body. So here it spread, if it is spread into the kidney, it causes your genitourinary tuberculosis. Okay. So most common tuberculosis reaches the genitourinary organ, from which route your answer will be through the blood. That is your hematogenous spread via the blood. Okay. So remember this: kidney, prostate, these are the primary site of the infection from the hematogenous route. Okay, मैं यहाँ पर लिख रही हूँ. So kidney, this is very important MCQ, plus prostate. Okay, so these are the primary site. Okay, for the tuberculosis. So lung से infected हुआ, from there via the blood, it can go into the kidney or it can go into the prostate, depend upon which part of the like organ को like sympathize होता है कि हाँ मुझे अभी इसमें TB होना चाहिए. Okay, so it's depend. So the kidney and the prostate, they can get tuberculosis from the hematogenous route via the lungs. Okay, whereas the other part, okay, that is the rest of the organs, they are by the ascent or the descent. So suppose bladder, ureter, ठीक है, seminal vesicles, they by the ascent or descent, they can affected from the tuberculosis. Remember, testis is not involved. ठीक है, testis is not involved in the by the Mycobacterium tuberculosis. So जितने सारे organs हैं in the genitourinary tract, the kidney, prostate, bladder, ureter, they can be affected by this by seminal vesicles also. They can be affected by the tuberculosis. Kidney and the prostate, they are the primary site, and the other site, they can be by the ascent or descent of the bacteria. Only testes is not involved. तो ये याद रखना, testes is not involved. So this is one of the very much most like MCQ question they can ask. Which testes is involved in tuberculosis? Your answer will be no. Okay. So now what happened? Now suppose there is an kidney. So first there is a formation of the granuloma. Okay, so these are the renal pyramid of the kidney. So there is a formation of the granuloma. Okay, thus there is a formation of the granuloma in the renal pyramid. They enlarges and they form tubercular abscess. They form tubercular abscess. When this tubercular abscess, okay, when they increases in size, they burst. Okay, with the pressure created within the abscess, they burst. Okay, and whatever they pass the discharge from the kidney, they enters into the ureter. Okay, they enters into the ureter. Okay, so burst into the pelvic system. Okay, and the whatever the pus discharge, they comes out from the ureter, and via the urinator we can see a pyuria. Okay, so this will be a sterile pyuria. So when you examine, you won't find any bacteria there. Okay, so that is the sterile. If the question asks the sterile pyuria, where you can see the sterile pyuria is one of the important like symptom of the or the sign of the like genitourinary tuberculosis. Okay, तो ये बहुत important है, that is your sterile pyuria. Okay, now its early manifestation is your vesical irritability. If they ask you what is the earliest manifestation, okay, so what do you mean by the sterile pyuria? Means pus is there, but you won't find any bacteria on the routine culture. The presence of the pus cell in the urine, but no bacterial growth. Okay, its most common cause is genitourinary tuberculosis. Okay, and if then what we will do, we have to do the AFB culture, okay, to know this, and the gold standard diagnosis with the TB and the PCR test. Okay, वो हम लोग बाद में देखेंगे. The first, if they ask you what is your first clinical like sign or the early manifestation of the genitourinary tuberculosis, okay, shall I write it here? यहाँ पर लिखते हैं. If they ask you what is the first early manifestation of genitourinary tuberculosis, so early clinical manifestation of genitourinary tuberculosis. GTB means genitourinary. Okay, your answer will be vesical irritability. Okay, vesical irritability. Okay, now what are the complications? अभी क्या हुआ यहाँ पर, सपोज पस बर्स्ट हो गया एंड देन कम्स आउट एंड वाया द यूरिन, it resulting into sterile pyuria. Okay, so this perinephric abscess, sometimes because it is a tuberculosis, the most common pathology it can go, it replaced by the caseous kidney. Okay, now suppose this is your TB of the kidney. अभी के लिए इसको सोचो, this is TB. Okay, the tuberculosis, it get burst. Okay, this abscess get burst. Okay, and sometimes what happen, this pus is replaced by your caseous material or caseous necrosis. Okay, which is one of the most common type of the necrosis occur in the TB. Okay, and which that time it is called the putty kidney. The putty kidney, it get calcified. When the kidney get calcified, when there is a no functions, okay, a calcified kidney is no non-functioning. So this is your end stage of the disease. Okay, when the whole kidney get calcified, it is your end stage of the kidney, and this is called autonephrotomy. Okay, an autonephrectomy. Okay, so remember, if they can ask you what do you mean by the putty kidney, where it is seen, okay, what do you mean by the autonephrectomy? Okay, it means the end stage of the kidney, when the whole kidney get calcified. Okay,
मतलब
autonephrectomy.
कैसे बन जाता है?
हाँ,
मैं बोल रहा था कि मैम जब बर्स्ट होता है, बर्स्ट होने के बाद वो इन्फेक्शन होता है, मतलब फिर वो जगह थोड़ा सा एक बार फिर से बताइएगा,
हाँ, अभी
आवाज नहीं आया।
देखो, ये पेरिनेफ्रिक एब्सेस है ना, दिस इज बेसिकली ट्यूबरकुलस एब्सेस है. सो इन पैथोलॉजी में हम लोग ने पढ़ा था ना कि जो एब्सेस, इफ द टीबी एब्सेस, इट्स मोस्ट कॉमन, जो इट गोज इनटू द सीरियस नेक्रोसिस है. ओके, it goes into the serious necrosis. There are two type of things. They can sterile pyuria. Sometimes it burst. Okay, कुछ part निकल गया, and then if some part of the perinephric abscess in the kidney, it goes into the serious necrosis. Okay, it goes into the serious necrosis which is called putty kidney. यही तुम्हारा क्वेश्चन क्या था, वो मुझे बताओ.
मतलब मैं उधर मैम आवाज तो ठीक से नहीं आया मैम, वो पोर्शन ही सुन नहीं पाया था.
अच्छा, फिर से बताओ कौन सा.
मतलब पुटी किडनी वर्ड सुन पाया, उसके थोड़ा पहले जो हुआ कुछ नहीं सुन
ओके,
पाया.
सो दिस इज पेरिनेफ्रिक एब्सेस है. ठीक है, means kidney का abscess है. Okay, perinephric abscess, when it is a tuberculous abscess, it changes into the caseous necrosis, caseous material, cheesy deposit, which is called a putty kidney. Okay, this putty kidney, it goes into the calcification. Now the whole kidney is calcified. Okay, when the whole kidney is calcified, that means it is an end stage of the kidney. It is an end stage of the kidney. The kidney is a non-functional. The kidney becomes shrunken. It is become non-functional. It becomes small in size. This is known as your autonephrotomy. यही है, ठीक है. So first it has start with the formation of the granuloma. Okay, then there is an, I think I written it here. First there is an formation of the granuloma, then the tubercular abscess. Okay, everything is occurring, but some type of the abscess is, if it is goes into the caseous necrosis, and these are the end stage that goes into the autonephrectomy. This is the ultimate stage of the genitourinary tuberculosis. Cessation, fibrosis, scar formation in the kidney, and the resulting autonephrectomy. ठीक है. एक दिन में नहीं होगा कैल्सिफिकेशन होने में टाइम लगता है. उससे पहले स्टेराइल पायोरिया, देन वी हैव टू डू द ट्रीटमेंट. इफ द राइट ट्रीटमेंट वाज गिवन एट द राइट टाइम, दिस इज नॉट गोइंग टू हैपन. दैट्स द थिंग. ठीक है. ओके, नाउ कम टू दी, अभी क्या है, या इन दी ब्लैडर. ओके, so this is all about your kidney. Now come to the already done the autonephrectomy. Now suppose, now if the tuberculosis in the bladder, okay, suppose if there is an it by the ascent or the descent is through the descent, the bacteria when enters into the bladder, it forms some nodules. Okay, now this is called your thimble bladder. Thimble bladder means fibrosis of the bladder mucosa. So first, when the bacteria enters into the bladder, it causes inflammation of the bladder. अब यहाँ पर लिखते हैं, I think, yes, here. Okay, let me remove this one. Now the bacteria enters into the bladder. ठीक है. Now mycobacteria through the descent, it causes inflammation of the bladder mucosa. Okay, it causes inflammation of the bladder. This is known as your tubercle formation. Okay, which is called as some nodules they form, which is called tubercle formation. Okay, so here you will see some nodules. Okay, on if you do the cystoscopy, there is some nodules you will find in the bladder. This nodule is called as a tubercle formation. Afterwards, in the later stage, fibrosis of the bladder. In the later stage, all the bladder become fibrosed. There is a scar formation and the bladder become fibrosed. Okay, this is known as your thimble bladder. Okay, इसको क्या बोलते हैं? Thimble bladder. Thimble bladder means tuberculosis of the bladder. Okay, now the same thing, if the vasa difference is affected, okay, so it looks like a beaded appearance. Okay, so in the vasa difference, when it looks like a beaded appearance. So there is a calcification of the prostate and beaded appearance of the vasa deferens. Okay, the early feature will be the vesical irritability. And how will you diagnose this case? Same thing, by the we have to do the AFP, acid-fast bacilli test, and to demonstration of the tuberculous bacilli in the urine by the culture called PCR. Okay, so important hai about your what is autonephrectomy. Okay, and what do you mean by this sterile pyuria? Okay, which are the organ is affected and which organ is spared in tuberculosis, genitourinary tuberculosis. Okay, so these are very much important. Or kuch, yes, one thing, so sometimes they will ask you a question, what do you mean by the golf hole ureteric orifice? Okay, So basically, this is seen in the Golf hole uretary corpus. It is seen in the cystoscopy. It is an early sign seen in the bladder tuberculosis. Okay, so cystoscopy in tuberculosis, the Golf hole ureter. Golf hole ureter. Okay, especially in the bladder, in the cystoscopy, when the tuberculosis is in the bladder. Okay, now let's move to the about your renal cell carcinoma. ठीक है? Anything? Yeah. Now come to the renal cell carcinoma. So what are the type? The most common is your clear cell carcinoma. Most common type 70 to 70% cases, origin from the proximal converted tubule. ये सब वन लाइनर है, इसको आपको याद रखना है. Mutation, chromosome 3p less, VHL gene, appearance will be yellow, lipid rich, aggressive, yeah, it has highly aggressive. Okay, so this is important. Most commonly they originate into the proximal converted tubule. Most common type of the renal carcinoma is your clear cell carcinoma. Okay. Now come to the papillary carcinoma. They are 10 to 15%, less common than that of clear cell carcinoma. They are divided into two type 1 and the type 2. Type 1 has a better prognosis. Type 2 has a worse prognosis. Okay, and the mutation gene will be MET proto-oncogene. This is your FH gene. Okay, and also they arises from the proximal converted tubule, and they also arises in the tumor arises in the proximal converted tubule. Okay, on histopathology, just like we can papillary carcinoma, we can see a Pasama bodies may be present. जैसे हम लोग ने थायराइड में पढ़ा था, papillary carcinoma of the thyroid, P for the Samoma bodies. Similarly, papillary carcinoma of the renal, we can also find the same bodies. Okay, so now chromoform renal cell carcinoma, they have a best prognosis among the all the renal cell carcinoma. ठीक है? It is only about 5%. Multiple chromosomes loses. Okay, and it's originate from the collecting duct, intercalculated cell of the collecting duct. Okay, so these are important, and this has a बेस्ट प्रोग्नोसिस. अगर कोई भी स्लाइड मिस हो जाता है तो बताने का टेक्स्ट में. ठीक है. नाउ कम टू दी कलेक्टिंग डक्ट कार्सिनोमा. They have rarely highly aggressive origin in the collecting duct, and they have a poor prognosis. In the histology, we can say some hobnail pattern. Okay. There is another which is called as a renal medullary carcinoma. It is associated with sickle cell trait and very much aggressive. ठीक है, ये याद रखना. They can ask you which is most exclusively associated with the sickle cell trait. Which renal carcinoma is associated with the sickle cell trait? Your answer will be renal medullary carcinoma. Okay, collecting duct carcinoma, it is highly aggressive, it has poor prognosis, and in histology we can say that hobnail pattern. ठीक है. Which has the best prognosis of the renal among the all the renal cell carcinoma? Your answer will be chromophobe renal cell carcinoma. ठीक है. Now suppose if they ask you what is the most common type of renal cell carcinoma? Your answer will be clear cell carcinoma. Okay. If they ask you what is the most common type of renal cell carcinoma which is associated with dialysis, the person is in dialysis for a prolonged period of time, they have more chance to develop papillary carcinoma. Okay. This is another important MCQ. Exclusively associated with the sickle cell trait is medullary carcinoma. Exclusively, if it is associated with the sickle cell trait, then this is your medullary cell carcinoma. Medullary cell carcinoma. Okay. And the best prognosis has the chromophobe carcinoma. Okay. So anybody want to see any slide? Chalo. Okay. So these are some paraneoplastic syndrome of the renal cell carcinoma. Okay, so there is an hypernephroma commonly causes increased of the erythropoietin. So there is an polycythemia, hypercalcemia, increase of the blood pressure due to the increased renin, hypertension, Cushing syndrome, and the feminization on the virilization. So these are the paraneoplastic syndrome of the renal carcinoma. Okay. Now, if they ask you what are the clinical features, any type of the renal carcinoma, the most common, the triad will be the two late triad. There is an hematuria. Okay. So gross hematuria, pain in the abdomen. Okay. And there is an abdominal mass. Abdominal mass. So these are the three triad. This is known as your two late triad. Two late triad. That is hematuria, abdominal mass, and the pain. These three together is known as your two late triad. And the most common, if they ask you what is the most common presentation of a renal cell carcinoma, your answer will be hematuria. Okay. And from the kidney, it can spread to the most commonly organ is in the lungs. So if they ask you the carcinoma from the kidney, the most common distance metastasis are the lungs. So in the lungs, we get a cannonball deposit, followed by the bones, then the liver, and then the brain. So renal cell carcinoma via the hematogenous spread, it can enter into the lungs, the most common in the lungs, followed by the bone, liver, and the brain. Okay. Okay. Now suppose if a patient comes to you with a varicocele, and if it is a, just a tip, if it is a right side varicocele, the most probably the cause will be renal cell carcinoma. Will we come to this when we do the varicocele part? Okay? So these are all about your renal cell carcinoma. Its most clinical manifestation is your hematuria. Okay? How will you diagnose the case? Diagnosis by the CT scan. Okay? 95% accurate, or the MRI, the most sensitive. It will also detect the tumor or thrombus in renal vein. Okay, so CT scan and the MRI is helpful for the diagnosis and for the confirmatory. Okay, sorry, the investigation. If they ask you what is the investigation of the choice, your answer will be CT scan, and MRI is most accurate. Okay. Remember, FNAC should not be routinely done in renal cell carcinoma because if it is not renal cell carcinoma, if it is an abscess, it can get burst. So because of this, FNAC is not routinely done in renal cell carcinoma. ठीक है, ऐसा नहीं है कि नहीं किया जा सकता, but it should not be done because if there is a renal abscess, it can causes burst of the renal abscess and resulting in other problems. Okay, so yeah. So now come to the Wilms tumor. So this is a most common primary tumor of the childhood, nephroblastoma. Okay, Wilms tumor or the nephroblastoma, usually 2 to 5 years of age. Second most common abdominal tumor in the children. Okay. Backslide. Okay. This one.
Okay, ma'am.
Okay. So, itna yaad rakho, what is the, if they ask you what is the most common primary renal tumor, your answer will be Wilms tumor. Okay. Or the nephroblastoma. It is the second most abdominal tumor in the children. तो most common abdominal tumor कौन सा है? AD is abdominal tumor, हाँ, AT. Most common abdominal tumor है nephroblastoma. Sorry, neuroblastoma. Okay, neuroblastoma. Second most common is your nephroblastoma. It arises from the kidney. It composed of all the three elements. Okay, B, latticeما, epithelium, and the stroma. The most presenting feature is asymptomatic abdominal mass or swelling. They are unilateral. ठीक है, ये सब important है. These are all the pointers. They are unilateral and they characterized by the abdominal mass, fever, and the microscopic hematuria. Okay, so these are the clinical classical triad of the Wilms tumor, abdominal mass, fever, and the microscopic hematuria. So if there is a continuous tumor, okay, if there is a continuous fever and the fever is not going down, it goes down after the resection of the tumor. Okay, so if after the resection of the tumor, fever also comes to the normal. Okay, so ultrasonography, the first investigation is the ultrasonography. Okay, and the other is a CT of the abdomen to know the abdomen for the staging. Okay, CT scan of the abdomen for the staging. So these are very important. इसके अलावा associated anomalies, nothing to do. So this important. They can ask you what is the most common primary renal tumor. Answer will be nephroblastoma, and most common abdominal tumor will be most common tumor in the children is your neuroblastoma, and most common malignant abdominal, second most common abdominal malignant tumor is your nephroblastoma. Okay, and first common is neuroblastoma. Okay, so this is all about your अभी ये थोड़ा important points है. The kidney is the mostly injured part of the urinary tract. Most common cause of the blunt renal injury is motor vehicle accident. Hematuria is the best indicator for the traumatic urinary system. Okay. What are the complications after the renal trauma? Urinoma Encapsulated fluid complication is the most common complications. Delayed bleeding usually occur within 1 to 2 weeks after the injury. Okay, so basically divided upon the early and the late manifestation. The early manifestation is the urinoma. There is a formation of the abscess. Okay, and delayed will be the hydronephrosis, pyonephrosis, stone formation. Okay, so remember, complications of the renal trauma is divided into the two part. Okay, so and complication is very rare, about 3 to 10%. One is your early, another is your late. ठीक है, so early complication में most common जो आता है, number 1 is urinoma. This is the most complication, followed by the delayed bleeding. Afterward, there is some urinary fistula or the abscess, where the late is your hydronephrosis, stone formation because of the injury made resulting in some plaque, or some causes fistula formation, so endovenous fistula. Okay, so these are the late complication. The early complication will be the urinoma, followed by the delayed bleeding. Okay. Okay. तो ये करने के बाद I think we have finished those. Okay, 1 minute. Adult polycystic kidney. It is about autosomal dominant. Chromosome affected is 16 and 4. Usually they are bilateral and important cause of the renal failure. Okay. So in adult polycystic kidney, so suppose this is your kidney. So there is a multiple cyst in the kidney. So these are all the pointers ko yaad rakhna. AD, chromosomes affected 16 and 4. They are mostly bilateral. Okay. Numerous bilateral cyst arises in the kidney. Okay. Cyst arises from all the segment of the nephron, but mainly on the collecting duct and the tubules. As a result, the kidney become massively enlarged in size. Enlarged in size up to 3 to 4 kg. Okay, 3 to 4 kg. So what are the most clinical manifestation of the adult polycystic kidney disease? This is hypertension. So hypertension is the most common clinical feature. Then the second will be the pain. If there is an infection in the cyst, it resulting in the pain. Okay. Afterwards, there may be hematuria. Okay, another thing, the most common cause of the death is a chronic renal failure. What is the most common cause of the death in adult polycystic kidney? This is chronic renal failure. Okay. The investigation of the choice will be the CT scan. The investigation of the choice is a CT scan. So adult polycystic kidney, they are autosomal dominant. Which chromosome affected? 16 and 4. They are unilateral. They are mostly bilateral. They are the one of the important cause for the renal failure. The death is also resulting into the chronic renal failure. There is a numeral bilateral cyst in the kidney, mostly on the collecting duct and the tubules. Okay. So this is about your adult polycystic kidney. So these are some extra renal manifestation. The person who is suffering from the adult polycystic kidney diseases: hepatic cyst, intracranial barrier mitral valve prolapses, pancreatic cyst, colonic diverticulosis, ovarian cyst. Okay, these are some extra renal manifestation. Okay, now come to the, what do you mean by the medullary sponge kidney? So medullary sponge kidney is what? These are the resulting in the cystic dilatation of the collecting duct in the renal medulla. Okay? This is very important. What is medullary sponge kidney? Cystic dilatation of the collecting duct of the renal medulla. They are congenital, usually asymptomatic until adulthood, bilateral in most of the cases. Okay, there are the cyst is there, but cyst is only 1 to 8 mm in diameter. They look like a sponge. So that is what is known as your medullary sponge kidney. Okay. So what are the common symptoms? Obviously, the most common symptoms will be the renal colic. Okay. And then there is a repeated UTI infections. So sometimes are due to the infections, if there is an infection in the type of the kidney or there is a formation of the stone. In CT scan is the best. In the IVP, in the intravenous urography, you will see a brush-like or the paint brush appearance. ये important है. Okay, in the IVP, that is our intravenous pyelography, which is one of the investigation of the choice. Okay, it will show your brush-like appearance. Okay, or the paintbrush appearance. Okay, just the kidney it's look like a it's look like a paintbrush. So there is some paintbrush appearance in the kidney like this. Okay, this is most commonly seen in the intravenous urography. तो middle sponge kidney में हो सकता है ये पूछा जाए brush like appearance or the bristle of the brush is seen in which type of the kidney? It is seen in the medullary kidney. Okay, medullary sponge kidney. Okay, now this is in another one. इसको सिर्फ इतना ही याद रखना. Here what happened, basically the lower pole of the kidney, they fuse together and they look like a horseshoe. So most common renal fusion abnormality. Okay, usually the lower pole of the kidney fuse together, usually seen in 1:4,000 number of the cases. Okay, 1:4,000 number of the cases. Fusion in the lower lobe. Okay. So one of the kidney, it will show some high and another in the low part. So low lying kidney, that is one is a kidney in the above part. The kidney gets stuck under the inferior mesenteric artery. So it is known as a low lying kidney. Usually horseshoe kidney, they are asymptomatic. If the symptom is present, the symptoms will be your abdominal pain only. So most symptoms are the asymptomatic. Symptoms occur if there is a stone and infection in the horseshoe kidney. Okay, the horseshoe kidney has an increased risk of UPG obstructions, recurrent UTI, hydronephrosis, renal stones, vesicoureteric reflexes. They are asymptomatic, but they have increased chances of this type of complications. Okay. And most of this horseshoe kidney, they are most commonly associated with the Turner syndrome. Okay, so this type of most commonly in the Turner syndrome. Okay. And they have an increased risk of the Wilms tumor. Okay, so these are some associated condition of the horseshoe kidney. Okay, इसके बाद So diagnosis by the ultrasonography and IVP, which shows a flower vase or the horseshoe pattern. Okay, so flower vase appearance is seen in which type of this kidney? In the horseshoe kidney. So here only this is important. Okay. Okay. Now another, we need to finish. I think we can't finish by today. Okay, now this is the normal, your kidney, bladder, the system, and this is an abnormal one. Okay, this is called a ureterocele. Previous slide. Okay, ये वाला ये छोड़ दो because it is an anatomical question. So this one. So इतना important है flower vase or the horseshoe appearance. Flower vase pattern seen in where? Okay. Okay. Previous slide to this slide. Okay. Okay.
I'm again previous to that one.
This one.
Yes, yes. Okay. Thank you.
Now we've come to the ureterocele. Okay. So So basically, ureterocele means cystic dilatation of the ureter. Okay, so if you see, this is a normal ureter, and there is some dilatation of the ureter. So dilatation can be any part, the upper part also, and suppose all, and when they enters into the bladder, there also. Okay, so this is called ureterocele. They are basically two type. One is your intravesical, which is also known as orthotropic, which is only about in 20% of the cases. Most commonly in the adult. Here the ureterocele lies inside the bladder. So just like this. Okay, so this one. So here the ureterocele lies inside the bladder, and usually single ureter is affected. Okay, so only one ureter, either right or the left, anybody. Okay. Now another one is your ectopic, which is more common. Okay, this is your more common. So here the part of the ureterocele extend into the bladder neck and up to the urethra. Okay, so it will go, the ureterocele can goes up to the urethra also, means this part also. Okay, so this is your ectopic ureterocele, a dilatation of the terminal ureter. Okay, not mostly the upper part, basically the terminal part of the ureter, divided into the two types, intravesical within the bladder. It is other name is your orthotopic, less common, only 20% of the cases, most commonly seen in the adult. And here, most commonly seen in the children, associated with the duplex collecting system. Okay, so suppose this is kidney, it has only one ureter, and sometimes the kidney has a two ureter. Okay, sometimes the kidney has two, one in the upper pole and another in the lower pole. Okay, so one in the opening will be the above the other one. So in this type of the duplex collecting system, especially in the upper pole, this type of the ectopic ureter is most commonly seen. Okay, so these are three are important. Most commonly is in 80% cases in the ectopic. Okay, Now, depends upon the age and depends upon the type also, we can see what are the clinical feature. So if it is in the children, so children, we know that mostly in the ectopic ureterocele, it's most commonly will be the recurrent UTI infections. Okay. So when there is an recurrent UTI infections, there is some hydronephrosis, poor urinary streams, okay, and they can often detected antenatally on the ultrasound. If it is in the adult, flank pain and ureteral reflex is more common. Okay, here in children, most common presentation is the UTI, and in adult, that may be the flank pain. Remember, if it is intravesical, okay, if it is within the bladder, here the most common clinical feature will be the repeated attack of the UTI infection. That doesn't mean it is not going to happen in the ectopic, okay, but most commonly in the intravesicals, okay. And here in ectopic, when the opening is in the urethra, here the most common symptoms will be the continence of the urine, okay. This is about ectopic ureterocele, okay. In the ultrasonography, the cystic trigon of the bladder, you can see the dilated ureter, okay, and the IVU or in the CT urography, you will see a cobra head appearance. This is the classical sign of the ureterocele. If they ask you, what is the classical sign of the ureterocele? This is your cobra head appearance or the snake head appearance. Okay. In the ultrasonography, you will see dilated ureter, hydronephrosis. Okay. The ureter is dilated, there is an hydronephrosis, there is some cyst-like thing in the bladder. In the eye view, this looks like a cobra head appearance. If the cyst looks like a cobra, if you see this one, look at this like a cobra head appearance, okay, in this way. So this is called as seen in the ureterocele, okay. Now, duplication of the ureter. That means two ureter is this, okay. So this is one of the most common congenital anomaly of the upper urinary tract. If they ask you what is the most common congenital anomaly, this is the most common congenital anomaly of the upper urinary tract, okay. Upper UUT means upper urinary tract. If you see this picture, this is a normal one. These are two type, one is complete, another one is incomplete. If you see the incomplete, it joins together, it start within two ureter and then they are joins together. This is your incomplete. So ureter that joined before entering into the bladder. But if you see this one, this is complete. Here the two ureter are present, okay. So one is in the, there are two opening of the ureter and there are two ureter. So this is called as a complete complete duplex ureter. There is a rule, if you see this diagram, that upper pole of the ureter, it goes behind to the lower ureter and they open into the just above the lower pole of the ureter, sorry, just below the lower pole of the ureter, okay. Now this is known as your Weygert-Mariel's rule, okay. So usually seen in the complex duplex kidney where the upper pole of the ureter, so if this is an upper pole of the ureter, and the lower pole of the ureter, when they are on their long abscess, the upper pole of the ureter is become medial and caudal to that of the lower pole of the ureter. So even they start, but the opening, if you see the opening just below the lower pole of the ureter. So this is known as your Weygert Mayer's rule. Okay, this is known as your, we get Mayer's rule. इसको सिर्फ आप डायग्राम देख के याद रखना तो ही याद हो जाएगा, ठीक है? So in male, the upper pole of the ureter opens into the prostatic urethra. Clinical feature will be the repeated UTI. In female, upper pole of the ureter opens into the anterior urethra. The most common feature will be the continuous incontinence with the normal voiding pattern. ठीक है, ये याद रखना. Okay. So prostatic urethra में खुलेगा upper pole of the ureter, repeated UTI infection. In female, in the anterior urethra, continuous incontinence of the urine. Here also we see the cobra head or the adder head appearance. Okay, because the dilation, there's a duplication, and when the ureter, it opens in the bladder, in the upper pole, it looks like a ureterocele. So it is also seen in the adder head or like a cobra head appearance. Okay, what are the clinical features? This is the only clinical feature, and sometimes they are the asymptomatic. If the feature is there, this is repeated UTI infections, and in female, continuous incontinence. Okay. So this is all about your duplication. Shall I move forward? उसके बाद हम लोग खत्म कर देंगे. In the next part से we will do the urinary bladder. किडनी और यूरेटर खत्म करने में 1 साल 2 घंटा लग गया मुझे. Okay. चलिए. So ectopic ureteral orifice. ठीक है. So usually this type of orifice is seen in most commonly in the duplication of the ureter. Okay, so 80% of the ectopic ureteral orifice is seen in the duplex or the duplication of the ureter or the duplex collecting system. ठीक है. So ureter open होना चाहिए bladder में, but look, it has opening into the urethral, lower urethral opening. Okay, but it does not form any cyst. Okay, it does not form any cyst. So this is called your ectopic. Around 80% of it is associated with your duplication of the ureter. Okay, it is same thing जो मैंने पहले बताया. In the upper pole, if the ureter enters, if opens into the posterior urethra, it causes repeated UTI infection. And in the female, if it is opens into the anterior urethra, the first answer is continuous incontinence of the urine. Okay, so this is same thing. One is duplication of the ureter, and suppose if the upper pole of the ureter and the lower pole to where it is open, it depends upon where is the opening. In case of male, it causes repeated UTI infection. In female, it causes your continuous incontinence of the urine with normal voiding pattern. Sometimes the patient will tell you, Kim, I have all my vagina is always wet. Okay, so there is an ureter opening in the vagina, so persistent vaginal discharge is always there. Okay, in the IVP, in the intravenous pyelography, you will see a drooping lily sign. So इतना ही important है. So drooping lily sign is seen in where? It is seen in the ectopic ureteric orifices. Okay. Yes. Okay. So this is all about your kidney and the ureter. ठीक है. Now, what do you, Randall plaque, what is this? Seen in the urinary stones. So if you see here in this kidney, there is some injury in the kidney. So some part of the injured is, part of the kidney is injured. After injury, there is an inflammation which resulting some later in the fibrate, calcification, okay, which resulting into the calcification. Now this calcification, if you see in the visible white patchy in the ureteroscope, this is called as Randall plaque. Okay, This is called as a Randall plaque. So this Randall plaque is what? It is in calcification, okay, which lies beneath the surface of the collecting, like in the kidney, okay, which in later part developed into the kidney stones. ठीक है. So kidney injured हुआ, वहां पर a small area of the kidney get injured, some tissue is injured, and as a result that area become calcified, which is called a Randall plaque. When you see in the urethroscope, you will see this white patchy areas. Now this white patchy areas, it's calcified, that may lead to the stone formation. So Randall plaque is a causes the urinary stones. Okay, so here the answer will be the urinary stones. ठीक है. So this is all about your kidney and ureter. What is the commonest stone in case of the UTI? Is it phosphate, urate, cystine, and the calcium oxalate? It is calcium phosphate. Okay, so renal stones which are laminated and irregular. Uric acid is not irregular, they are very smooth. Struvite, we have seen that it looks like a staghorn calculi. Calcium oxalate is laminated and irregular in outline. Okay. So what do you mean by the diatal crisis? A swelling in the loin is associated with acute renal pain. Some after the later the swelling disappear when a large amount of the urine is passed. So this is diatal crisis. ठीक है, ये पूछा जाता है. What is diatal crisis? Okay. Okay. Still have 20 minutes left. बस 2 मिनट का ब्रेक लेते हैं, उसके बाद मैं आती हूँ. ठीक है. If you have anybody have any questions or any slide missed, just type me in the chat box. ओके, स्टार्टिंग साइड में लास्ट में आपको दिखा दूंगी. ठीक है, थोड़ा ब्लैडर कंप्लीट कर लेते हैं एंड देन वी विल फिनिश दिस वन. उसके बाद नेक्स्ट में बाकी का प्रोस्ट्रेट ये सब रहेगा. ओके. Okay, now let's move to this bladder extrophy. Okay, और ectopic वैसे ये भी बोलते हैं. नंबर 1 फर्स्ट है कंजेंटिनल एनोमली, ये एक है पॉइंटर. ठीक है. सेकेंड क्या है? द एंटीरियर एब्डोमिनल वॉल एंड द एंटीरियर वॉल ऑफ द ब्लैडर, दे आर फेल टू डेवलप. ठीक है, दिस इज सेकेंड पॉइंट. एज इट happened, what happened? The posterior bladder wall lie open and exposed out of the body. So these 3 things है. ठीक है, तो एक में क्या होता है? नंबर 1, it is a congenital anomaly. Anterior abdominal wall and anterior urinary part wall of the urinary bladder is absent. ठीक है. So this is basically a developmental incomplete development of this anterior abdominal wall. Okay. So, what are the clinical point? Bladder mucosa is exposed outside the lower abdomen. दिख रहा है, ठीक है? Urine dribbles continuously because there is no bladder outlet. Kidney है, ureter है, bladder का outlet नहीं है, तो urine dribbles continuously. Okay? Widened pubic symphysis associated with your epispadias. Umbilicus is low placed. Genitalia are abnormal and increased risk of UTI and the adenocarcinoma later in life. Okay? So these are the important pointers for the ectopic vesicae. So quick multiple choice questions में ectopic vesica is also known as bladder extrophy. Associated with epispadias. In the later part, I will tell you what is epispadias because there is an opening in the upper part of the penis. Okay. So causes is your failure of the mesoderm migration. Okay. And risk of the adenocarcinoma if untreated. Okay. Okay, now come to the bladder calculi. Primary bladder calculi and the secondary bladder calculi. Primary bladder stone seen in where? In the underdeveloped countries such as Burma, Indonesia, Thailand, Africa. Okay. Most commonly they are seen in the children up to 2 to 4 years of age. Okay. And remember, boys are more common than that of the girls. Most common stone will be your ammonium urate stone and the calcium oxalate stone. Remember, the primary bladder stone is in basically here the stone is developed not due to some infectious factor or not due to some anatomical defect. ओके जैसे कि रैंडल प्लाक हो गया तो स्टोन फॉर्मेशन हो गया, कुछ इन्फेक्शन हुआ, ब्लैडर आउटलेट ऑब्स्ट्रक्शन हो गया ड्यू टू प्रोस्टेट, ओके, और देयर इज सम स्ट्रक्चर. Primary bladder stone is not like this without any anatomical defect, without any known functional on the anatomical defect. Usually seen in the children, and the most common will be ammonium urate and the calcium oxalate. Okay. So children having chronic dehydration, exclusive breastfeeding, high carbohydrate, low phosphate intake, and rarely occurs after the treatment. Okay. Now secondary bladder stone seen if there is in some developmental problems. Okay, for example, or there is in some foreign body. For example, if there is in benign prostate hypertrophy. Okay, if there is in some strictures which causes an obstructions or any type of the foreign body if it is present in the bladder stones. Okay, here the most common is your uric acid stone and the steroid stones. Okay, so uric acid stone and the steroid stones. Catheter, yeah, bladder diverticula, anything which resulting into the secondary bladder stones. Okay, so these are some predisposing factor for the secondary bladder calculi. Clinical feature will be the same: intermittent painful voiding of the urine, severe pain at the end of the micturition, passage 1 to 2 drops of blood at the end of the urination called as terminal hematuria. Okay. In USG, we'll show a characteristics shadowing. Also, if you go with the USG, you will see that the stone is moving here and there. Okay, the stone is also moving. Okay. Most common stone if in the urinary bladder, if they ask you what is the most common stone in the urinary bladder, your answer will be uric acid stone. And if it is in the kidney, the most common stone is your calcium oxalate. And if they ask the most common stone in the prostate, then your answer will be calcium phosphate. Okay. Okay. So these are all about your bladder stones and this. So egg bladder stone, primary, there will be no anatomical defect, no structural defect, whereas a secondary, there are some cause should be there. Okay. Now, what do you mean by the malakoplakia? Okay. अभी इसमें होता क्या है? For example, a person is suffering from recurrent UTI infection. ठीक है? Now, because might be that person is diabetic, or he is an immunocompromised person suffering from HIV or anything, suffering from rheumatoid arthritis, any autoimmune diseases. Okay. Now, because of the repeated UTI infection, the macrophages, or if the person is immunocompromised, the macrophage does not complete its action. As a result, there is an accumulation of the debris in the bladder. Okay. So that is why it is resulting due to the incomplete killing of the bacteria, which causes an accumulation of the debris. Okay. So what is the most common site? That is bladder is the most common site for the malakoplakia. Usually most common seen in the women than that in the men. So what happened? So basically most commonly UTI, that is in the E. coli. Okay, other is a Proteus and Klebsiella seen in this type of the patient, immunocompromised, diabetes, and the transplant patients. So what happened actually here? Okay, now suppose this is your bladder. Now repeated UTI infection, the macrophages cannot kill all the bacteria. As a result, there is an undigested bacterial fragments are always there. Okay. Now when they form, because of the inadequate bacteria, because of the defective phagocytic activities, okay, there is a formation of the plaque. There is a formation of the plaque or the nodules in the bladder. Okay, so there is a formation of the plaque or the nodules in the bladder cell, which is called as a Michel-Gutmann bodies. Formation of the Michel-Gutmann bodies inside the macrophages. Okay, so there is a formation of the plaque, nodules. Okay, this plaque and the nodules of large histiocytes. This plaque and the nodules is also there. Okay, and some bodies are also there which is present inside the macrophages. These bodies are known as your Michel-Gutmann bodies, and this plaque is called as an von Hansen cells. Okay, von Hansen's cell. ये दोनों important है. Michel-Gutmann body is found in where? It is found in the your malakoplakia. Okay. Now, as a result, so clinical feature will be what? There is in recurrent UTI infections and hematuria, dysuria, and sometimes there is a mass lesions in the bladder wall due to the incomplete killing, which mimic sometimes carcinoma. Okay, urine culture often you show the E. coli. Imaging will show the plaque and the nodules, and the biopsy will confirm this Michel-Gutmann bodies. So Michel-Gutmann bodies is one of the biopsy finding for the malakoplakia. Okay, the culture will also show E. coli. So these are the high line, one liner. कौन सा common malakoplakia का most common organ क्या है? Bladder. Which is the most commonest organism is E. coli. What you find in the biopsy, Michel-Gutmann bodies. It is a pathognomic sign of this malakoplakia. Why it has happened? Due to the defective phagocytic activities. Okay. So these are the malakoplakia. Okay. Usually seen in whom? Women who has an seen in mostly in the women. The person is mildly immunocompromised or the diabetes or lymphoma, okay, or maybe on high transplantation or high steroids, their immunity is always low. As a result, whenever there is an infections in the tract, they are not going to killed properly, okay, which resulting in the malakoplakia. Okay. Now, what is this? I'm going very fast. Just wanted to complete this. अगर किसी का छूट जाता है तो बताना. Okay. So this is one of the parasite. Okay, this is known as your schistosomiasis or the bilharziasis. Okay, they affect any part of the intestine, like in the body. But if it is your hematobium, B for bladder, that is why hematobium is mostly in the disease focus in the urinary organ. Okay, especially in which organ? Especially in the bladder. Mansoni, it is usually in the intestine. Its specialty disease focus in which organ? In the large intestine. Okay, and this is your S. japonicum. It's a disease, most severe one, and it's mostly in the your small intestine and the liver. This is the most severe one. ठीक है, तो इतना याद रखना. तो urinary bladder में जो parasite आता है, that is known as a Schistosoma hematobium. This is a causative species. Okay. Now what happened here? Okay. Now this parasite, it will hatch egg in the fresh water and will produce miracidum. Now this miracidum, they enters into the snail. Now snail has become an intermediate host. Okay. Now this snails which develop some Carceria. Okay. Now they develop Carceria. Now this Carceria penetrate into the human skin. Now the human has become your definitive host. Okay. So egg is intermediate host is your snail. The definitive host is the human. Okay. So from the human skin, it is the bladder, blood, in the liver, and then goes into the venous plexus of the bladder. And they now, when they enters into the bladder, they release eggs. Okay, and these eggs are highly antigenic. Okay, they release an highly antigenic, which causes some inflammation and granulomatous reaction, and they form a granuloma. Okay, the granulomatous reaction, which causes bladder fibrosis, which causes a bladder fibrosis. Okay, and ultimately this eggs, this eggs, it becomes calcified. They become calcified, which causes bladder stones. Okay, which causes bladder stones. So kya hua? Egg in the urine, they reach the fresh water. From they hatch miracidium. Miracidium enters into the snail. From the snail, they develop Carcedia. Then they enters into the human skin. From the human skin, via the bladder, from the enters into the bladder through the venous plexus. In the venous plexus, this they become now the adult form, it becomes release eggs. Now these eggs are very much highly antigenic, and they cause an antigenic reaction. They form a granulomatous reaction, which causes fibrosis of the bladder. Means after the fibrosis, there is a stricture formation and this scar formation, which causes bladder outlet obstructions. Okay, now this adult worm, now the egg which is present, some egg which is present in the bladder, it is calcified and causes bladder stone. Remember this, Schistosoma hemibium is one of the cause of the bladder cancer, especially the squamous cell carcinoma. Okay, so not the adenocarcinoma, the squamous cell carcinoma. Okay, this is one of the cause of this squamous cell carcinoma of the bladder. It is one of the serious complication of this parasite. Okay, so
Please show previous slide.
sorry,
Previous slide, can you show?
this one.
Yes.
Okay, इसको करके ना we will finish this. Okay.
Okay, ma'am, done.
Okay. So अभी Now human, they go to the water to swim, river to swim. So first clinical, now if this Coccidia, that if they enters into the skin, the first reaction will be a itch, which is called as a swimmer's itch. Okay, usually occurs within the first 24 hours of the cardiac penetration. Okay. Okay. Afterwards, that is in within the 3 weeks to 4 months. Okay, within the 3 weeks to 4 months. When all the cycle has gone, the egg started laying, okay, the generalized allergic reactions you took some skin itches, anything, it gets suppressed, okay. Then after 3 to 4 weeks, these are the acute manifestation of the Scisshotoma hematobomi, which is known as a Catamia fever. There is a fever, urticaria, increase of eosinophilia, and the abdominal pain. Usually occurred within the 3 to 4 weeks of after the carceral penetration. Okay, and but the most common symptoms of the urinary schistosomiasis is urinary frequency. Urinary frequency. So in the history, you need the past history, whether this type of anything happened or not. You went to the pond and there is some problem, itching, which some allergic reaction has been taking place during that time. For that, you have used any ointment or not. Okay, so in this way, you need to probe the things. Okay, so Catamia fever and the swimmer's itch, these are the clinical manifestation in the human, and urinary frequency is the first presentation of the Scisshotoma hematobium. Okay, this is the most common, not the first presenting symptom, the most common symptom. The first presenting symptom is the itch only. Okay. Okay. So chronic disease, so hematuria, the terminal hematuria, calcified bladder. If you go with the cystoscopy, we will see a sandy patches, and they have more chances to develop squamous cell carcinoma of the bladder. Okay. So how will you diagnose this case? Through the microscopy, you will see eggs in the urine. Urine sample should be collected in the morning, 10 a.m. to 2 p.m. ELISA test or cystoscopy will tell you the sandy patches. Bladder wall thickening and the calcification, which looks like a fetal head appearance. Okay, which looks like a fetal head appearance. Okay, so ये सब important points हैं. Okay. You can just tell me which species of Scisshotoma is the most commonly associated with the squamous cell carcinoma of the urinary bladder? This is Scisshotoma hematobium. Yes. This one, a stool sample shows an ovum with the lateral spine. Which parasite is the most likely the cause? If I have already in that chart, if you can click that picture, you can give me the answer. Though it is most related to pathology. Is it your Scisshotoma mannsoni? Okay. So the answer is here. Lateral spine. Okay. Egg shape is like a lateral spine. Okay. Now come to the last one about the bladder rupture. Okay. So bladder rupture are two types. One is extraperitoneal, another is your intraperitoneal. This is more common, most common. Okay, 80% of the cases. अभी देखो this diagram, extraperitoneal is towards the outside, intraperitoneal towards the peritoneum. ठीक है, दोनों में से extraperitoneum is more common है. ठीक है. Extraperitoneal bladder fracture, the most common is a pelvic fracture due to the road traffic accident. Okay. And there is a suprapubic pain and difficulty in passing the urine. If you go with the cystoscopy, you will see a tear-shaped bladder, flame-shaped bladder, pear-shaped bladder. Okay, can be treated by a simple catheter drainage. Okay, now this is your intraperitoneal, which is only about 20%, especially the rupture of the dome of the bladder, causing urine to leak into the peritoneal cavity. Now, if you can see, intraperitoneal, why? Okay, so bhitar. Okay, so within the peritoneal cavity, urine is leaking. Okay. So most commonly is the blow to the distended bladder, fall, RTA, sports injury. Okay, but there is a blow, fall, or kick in the distended bladder. Okay, and the also seen in the iatrogenic injuries. Most common sign is in the dome of the bladder. Okay, usually seen in the male. Okay, so here there will be the sign of peritonitis, generalized abdominal pain is present. Okay, so there is some classical triad you will see. One is your pain, generalized abdominal pain, or suprapubic pain is also there, but it is less than extraperitoneal. Difficulty in passing the urine or inability to pass the urine, and patient develop a sign of a peritonitis. So these are the three triad. एक है suprapubic pain, okay, one suprapubic pain, two inability to pass the urine, and the sign of the peritonitis and abdominal distension. Okay, so this is in the intraperitoneal bladder rupture. In here, you will see a sunburst appearance in cystography. X-ray will show a ground glass appearance. Okay, this is important one. Now, carcinoma of the bladder. Most common is your TCC, squamous cell carcinoma, most commonly seen in the schistosomiasis. Third is your adenocarcinoma. ठीक है, मुंह कार्सिनोमा का मोस्ट कॉमनेस्ट क्लिनिकल फीचर क्या है? पेनलेस ब्लीडिंग है, पेनलेस हेमाचूरिया. ठीक है, so these are the some of the risk factor of the transitional cell carcinoma. So if you read the drug terebinth is usually prepared from oil of turpentine. Okay, turpentine oil, and it is one of the drug for the bladder cancer if there is in painless hematuria. I've never used, but yeah, it is because the person who is working in the turpentine factory, they usually develop the bladder cancer. So in that analogy, we can use this case. Okay, so these are the some of the risk factor for the TCC. And squamous cell carcinoma, the risk factor most commonly is the schistoma hematobium. Okay, these are the other risk factor: bladder stone, bladder diverticula. Okay, and usually seen the transitional carcinoma most commonly seen in the males, 5th to 6th gate, and usually most common site is your posterolateral wall and the trigone of the bladder. Okay, this is the most common site for the transitional cell carcinoma. Most common feature will be a gross hematuria. Most common lymph node will be the obturator group of the lymph node. Most common metastasis, distant metastasis in the liver. Okay, so these are the how the diagnosis case. Gold standard will be your cystoscopy and the biopsy. Elderly male will produce a painless gross hematuria. Also, there is an emergency vesicle irritability. Okay, and if there is a spread, most common lymphatic spread into the obturator group of the lymph node, and most common hematogenous spread in which site? In the liver. Okay, and these are some tumor marker of the bladder cancer. Okay, so this is completed. In the next part, we have remaining the prostate, urethra, testes and the scrotum. ठीक है, ये finish कर देंगे and then we will start the general surgery. Okay, so कौन सा slide किसको देखना है? Let me know.
मैम स्टार्टिंग स्लाइड्स.
Starting ना?
यस मैम.
So this one,
यस मैम। मैम सबसे पहले वाली दिखा दीजिए। ओके मैम।
okay. So shall we wind it up for today? और किसी को कुछ देखना है? और तो कुछ नहीं है ना, तो बहुत फास्ट हो रहा है। या आई नीड टू कंप्लीट दिस बाय फरवरी, इसीलिए you can ask to Taha or anything about their, if they give you a recorded one, that will be good, because I need to complete this, अभी बहुत बाकी है, okay, इसीलिए, otherwise, but I need to cover everything. GIT मैंने बहुत स्लोली लिया था, so it take about 3 classes, that's the thing. और किसी को पूछना है कुछ, so I will wind it up for today.
मोनोजेनिक
And
डिसीज
हाँ,
मैम, पॉलीसिस्टिक किडनी डिसीज में इस बार 25 में आया था कि मोस्ट कॉमन लाइफ थ्रेटनिंग मोनोजेनिक डिसीज इज एन एडल्ट पॉलीसिस्टिक किडनी डिसीज। तो
समझ में नहीं आया, मुझे क्वेश्चन एक बार लिख के दे दूंगी यहाँ पर।
स्टेटमेंट था
हाँ,
एडल्ट
स्टेटमेंट था, मुझे क्वेश्चन
हाँ।
एक बार दे दो ना, मुझे इसमें दे दो, नेक्स्ट क्लास में मैं अगर कुछ मुझे नेक्स्ट क्लास में मैं ये कर दूंगी। एडल्ट पॉलिसी
आपने बताया कि
दे दो, नेक्स्ट क्लास में मैं अगर कुछ मुझे नेक्स्ट क्लास में मैं ये कर दूंगी, ठीक है? एक्चुअली मुझे बहुत ज्यादा अभी आई एम फील एग्जॉस्टेड नाउ एक्चुअली, इसीलिए, ठीक है? सो यू नो माय नंबर। कौन बोल रहा है एक्चुअली? हेलो, चलो।
मैम
So if you have any question, na, just directly write me in my chat, in my message, okay, WhatsApp message, if you have my WhatsApp number, ठीक है? और या तो शेयर कर देना किसी को भी, so that I will get the to the Taha और डॉक्टर नाजरा, ओके? मैं देख लूंगी एक बार क्वेश्चन क्या आया है, बिकॉज आई विल इन द लास्ट क्लास ना, द 2025 के जितने सारे क्वेश्चंस है ना, वो मैं करवाऊंगी, सो वो वहां पर आ जाएगा, ठीक है? डोंट वरी, ओके? ओके, एनीबडी और किसी को कुछ पूछना है? चलो देन, थैंक यू एवरीवन।
मैम लास्ट क्वेश्चन।
हाँ,
मैम मोस्ट कॉमन कॉज ऑफ डेथ आपने बताया कि क्रॉनिक किडनी फेलियर होता है, एक्यूट
थोड़ा
पॉलीसिस्टिक
जोर से
किडनी
बताओ
डिसीज।
कि प्रीति, अब मुझे तुम्हारी आवाज सुनाई नहीं दे रही है एक्चुअली, क्या बताया आपने?
मैम मोस्ट कॉमन कॉज ऑफ डेथ इन
हाँ
पॉलीसिस्टिक किडनी डिसीज, आपने बताया कि क्रॉनिक रीनल फेलियर होगा।
हाँ
तो
हाँ,
मैम सीवियस डिसऑर्डर नहीं है क्या?
प्रीवियस डिसऑर्डर,
हाँ, कार्डियोवास्कुलर।
अच्छा सीवियस डिसऑर्डर, एक्चुअली ना मैं बोलती हूँ करके, ठीक है? क्रोनिक रेनल फेलियर का डेथ, जब भी इस तरह के डेथ होते हैं ना, तो स्पेशली जो डॉक्टर्स कार्डियोवास्कुलर अरेस्ट ही वहां पर होता है, एनी टाइप ऑफ दैट इज सडन डेथ है। क्रोनिक रेनल फेलियर इज मोस्ट कॉमन कॉज ऑफ द डेथ है। कार्डियक अरेस्ट होके वो डेथ हुआ, वी कैन अंडरस्टैंड बिकॉज ब्लड सप्लाई एंड एवरीथिंग दैट, बट इन एमसीक्यू क्वेश्चंस, the adult polycystic kidney, because that resulting into the destruction of the kidney, which resulting in the death of the patient in a chronic phase, ठीक है? सडन में नहीं है कि डायलिसिस लेते रहते उसको कार्डियक अरेस्ट हुआ तो वो चला गया, दैट द डॉक्टर हैज राइट द डेथ बाय द कार्डियक अरेस्ट, यही है, ऐसा ही होता है।
ओके मैम। मैम तो इन्फेंटाइल में होना चाहिए ना क्रॉनिक फेलियर?
एडल्ट में भी तो होता है,
एडल्ट
दोनों में ही
एडल्ट
होता है।
ओके मैम।
एडल्ट
मुझे लगा
पॉलिसिस्टिक किडनी डिजीज है ना, तो दोनों में ही होगा, पॉलिसिस्टिक किडनी। एंड दिस इज बेसिकली, आई अगर आप पुराने पुराने सर्जरी के बुक्स पढ़ोगे ना, हैरिसन प्रिंसिपल्स इन द ओल्डन डेज, इट वाज रिटन, अभी तो पता नहीं, पर पहले के लाइक 70s 80s के जो बुक्स में वहां पर लिखा था कि, अभी वो सब मैं तुमको बता रही हूँ ऐसे ही, कि व्हेनेवर देयर इज एन एनी सिस्ट ना, नेवर डू एनी लाइक नाइफ, नेवर ट्रीट दिस विद नाइफ, मतलब सर्जरी नहीं करने का है, ठीक है? एंड इफ यू डू द सर्जरी दैट विल रिजल्टिंग इनटू दिस क्रोनिक रेनल फेलियर, बट नाउ इन फ्रॉम अभी के बुक्स में आपको ये सब नहीं मिलेगा, सो दिस इज ओनली फॉर योर नॉलेज। अगर किसी को भी किडनी सिस्ट होता है ना, ट्राई नॉट टू ऑपरेट दैट थिंग, लेट इट बी। ये सिर्फ मैंने आपको इन्फॉर्मेशन के लिए बोला है, बट आई हैव सीन दिस टाइप ऑफ द केसेस, इसीलिए। तो एमसीक्यू रिलेटेड एआईपीजीटी में अलग है, बट इफ यू स्टार्टेड टू डू प्रैक्टिस, द क्लिनिकल विल बी समहाउ डिफरेंट, बहुत सारे अलग अलग तुमको देखने को, जो तुमने पढ़ा है वो तुमको लगेगा कि अरे ऐसा कैसे हो सकता है, ये है, ठीक है,
ओके ओके
और
ओके
कुछ? सो नेक्स्ट क्लास सैटरडे या संडे को ही होगा, और जनरल सर्जरी शुरू करेंगे, और बाकी के जो ट्राइक बाकी है